Thank you, Juan. I'm going to probably be somewhat redundant on some of the stuff I'm going to show, but I'm going to go quick through it, and I know we're crunched on time. So you're sitting in the office, this patient shows up in your office, and I've had a fusion before, so what's the problem here? So you look at it, and if you look at it simplistically, you don't know why is this patient hurting until you do your parameters, and you find out that this patient was brought from a lumbar lordosis of 58 degrees down to 28 degrees. So now this patient has a significant sagittal malalignment. This patient had a 3-level ALIF, and despite that is significantly sagittally malaligned. So you just converted a L3-4 mild degenerative spondy into a major deformity case. This is where I'll call my friend Jens and I say, hey, Jens, you got to deal with this. I don't know what to do with this. This is an everyday case, right? I mean, this is like a TLIF, single-level TLIF on a young patient. This patient is a 42-year-old athletic lady, had a TLIF, and then she shows up in my office with this. So you do some parameters, and you find out that the mismatch is 26 degrees between pelvic incidence and lumbar lordosis. So is that an iatrogenic deformity, or is that something that was missed from the beginning? When we apply the parameters, we find out that she's severely sagittally malaligned with a 25-degree discrepancy between the two. So we got to recognize the deformity, don't create a deformity. And so I'm going to go over some of the lateral techniques available for correction of sagittal deformity. So we'll go over some principles that are very important to understand. And then we're going to go over the lateral approach. And then eventually we're going to do a lab. So that's why on the technical part, I'm not going to belabor that on this presentation. So considerations in adult deformity include sagittal plane, coronal plane combined. Usually it's an advanced degenerative disc disease resulting in deformity, or it's just progression of idiopathic scoliosis. And sometimes, of course, it's iatrogenic deformity, and we see that all the time. Also, curves could be rigid or could be flexible. The population is getting older, and people now live longer and live healthier. So we're seeing more and more operative candidates, and this especially applies if we are able to do that in MIS fashion, as was mentioned earlier by Dr. Taylor. We're able to help those patients now with maybe 2 or 3 level surgery and attend their needs. So adult deformity leads to disability. It's usually progressive, and neural compromise varies from patient to patient. You can have the patient with radicular pain, or you can have the patient with neurogenic claudication. And almost all patients have axial back pain. So adult patients are different than idiopathic scoliosis. You have stiff curves. You have degeneration of the discs. You have osteoporosis. You have rotary subluxation. This patient has had previous laminectomy, now has significant deformity. And also, you have significant hypolordosis in these patients. Typically, these patients are more than 50 years old, 68%, up to 68% prevalence, mostly female. A lot of them have osteoporosis, and a lot of them have asymmetric degeneration of the discs. So the deformity itself is not the indication for surgery. I mean, everybody has seen patients walking in with a 45-degree scoliosis, but they say, hey, I can live with the back pain. Am I going to correct that deformity? Absolutely not. But if that patient says, I have unilateral leg pain and they have asymmetric degenerative disc collapse with, let's say, L4 radiculopathy from an L4-5 tilt, then I may do something for that patient, and it's going to be only at that one level, just to restore that foraminal dimension and relieve the leg pain. Also, you want to see if the patient has pulmonary or neurologic compromise and see their functional limitations. So you're going to modify the strategy depending on the presentation. Does this patient have just leg pain? Does this patient have decompensation? Does this patient have osteoporosis? What are the comorbidities in that patient? And really custom fit that surgery. So not everybody is going to need a T10 to pelvis procedure. Not everybody is going to need an open procedure. And I think everybody in this room would admit that these kinds of open procedures do have high morbidity, and treatment is limited to some patients, meaning that you have some patients with comorbidities who may have contraindications to a procedure like this. So the options are you can do all posterior with posterior osteotomies, with T-lifts, spliffs, or you can do paramedian for low lumbar or thoracolumbar approaches, or you can do a multi-level lateral approach, which is what we're going to discuss today. Dr. Chapman earlier mentioned about some muscle bulging seen with these procedures. This is due to either, we call that either pseudo hernia or, it doesn't have to be like you cut the nerve, but you could stretch the nerve and get that pseudo hernia. And traditional approaches, mainly posterior approaches, osteotomies, and we're discussing here SPOs, PSO, and vertebral body resection, known to have significant morbidity, significant complications, and 2 to 3 liters of blood loss. And in a series by Dr. Shaffrey's group, PSOs, carried a pretty significant complication rate, including dural tear, wound infection. Wound infection, 3.7% deep infection. That's pretty high in this population. Neurologic deficit in 7%. So let's go a little bit over sagittal alignment principles so that we can understand that. Dr. Dubosset's principle of the reverse cone, basically, you have to be able to stand within that cone, and any deviation beyond the limits of that cone is going to put a lot of demand on your muscles. And then you're trying to compensate, and you get muscle fatigue, which is one of the sources of pain. So you got to keep your patient within that cone. You got to stay within that. Now, in the past, everybody talked about SVA. Everybody talked about the plumb line. But if you just look at the plumb line by itself, it's almost meaningless if you don't take into account the pelvic parameters. But even with that said, if you have an anterior shift of the plumb line, that's associated with increasing disability, and that has been documented in literature. And so if you have more lumbar kyphosis, also it's associated with more disability, looking at the SRS 29 and ODI. And as you have more positive balance, you're going to have lower quality of life, so health-related quality of life, where your ODI increases with positive sagittal balance, and your quality of life decreases. So what is lumbar lordosis? When I was a resident, they told us lumbar lordosis has to be between 30 and 60 degrees. Well, at the time, we were not familiar with terms such as pelvic incidence. And what does that mean? So lumbar lordosis basically is the angle between the superior end plate of S1 and the superior end plate of L1. By itself, it's meaningless. You got to look at the others. However, again, with all that said, if you have more kyphosis in the lumbar spine, you're going to have deterioration of the ODI score. So you're going to tolerate more kyphosis in the high thoracic spine than in a lumbar spine. So as your kyphosis moves distally, then your ODI score is going to go up, which is disability score. Same thing with lumbar lordosis. As you shift into lumbar kyphosis, you're going to have poor tolerance and you're going to have increased disability. What is pelvic incidence? Pelvic incidence is a morphologic parameter. This is how God made you. This is the relationship of your femoral head to your pelvis. Pelvic incidence is not affected by patient position. You can have a patient lying down on the OR table. You can measure pelvic incidence on the OR table. You can measure it in the standing X-ray. You can measure it on the lying down X-ray. It's a constant relationship, unless, of course, you do a sacral osteotomy. But it's a constant relationship, and that's going to be a guide that tells you how much lordosis you need in every single patient. So what we're doing here, as the patient is tilting the pelvis back, changing their pelvic tilt, the pelvic incidence is not changing. So the sacral slope is changing, pelvic tilt is changing, but not pelvic incidence. So if you have a large pelvic incidence, it requires a large lumbar lordosis. It's as simple as that. Rossouli, a French guy, came up with a classification, and it's like A to D. And it's four different levels where you move from a low requirement for lordosis to a higher requirement of lordosis. So when you look at this one, this is where you have a high pelvic incidence that requires a high lumbar lordosis in order to achieve balance. If you have less pelvic incidence, then you need less lordosis. And this brings us back to where lumbar lordosis by itself is useless unless you are able to measure pelvic incidence. So there is nothing magic about these numbers. All we're saying is we got to have these numbers match, because the pelvic incidence, which is a morphologic parameter, requires a certain amount of lordosis in order to achieve alignment. I don't know what's happening here.
Jason, you got it?
Yeah, he's running back deck. So any questions so far about PILL, pelvic incidence lumbar lordosis? Okay.
Just click next. Is it up? There we go.
Okay, so what is pelvic tilt? Pelvic tilt is when the patient tilts their pelvis in order, it's doing it again. Patient tilts their pelvis in order to compensate for deformity. So what they're doing, they're retroverting their pelvis in order to stand up straight. So that measurement is taking from the center of the femoral head to the center of the sacrum, and this is positional. So that's why we tell people take standing X-ray. The reason you take a standing X-ray is because now you're able to measure pelvic tilt, and which is very important. You cannot measure pelvic tilt on a lying down film or measure pelvic tilt in the OR in a patient on the OR table. So I'm doing it again. So it's a positional parameter and shows you how much is the patient compensating. So it's the angle between the center of the femoral head to the mid-sacrum, and that angle with the vertical. Am I pushing this one?
You might be pushing that one or this one.
Okay. So it's a compensatory mechanism. So as the patient retroverts their pelvis, you're going to have increased pelvic tilt. So that's a parameter you want to look for. So what does that mean? That means that you could have somebody with a large SVA, with a large sagittal axis distance, with a plumb line, but no pelvic tilt. What does that tell you? That tells you that patient is decompensated, but that patient is not trying to compensate via pelvic tilt. Again, SVA by alone is also not very useful. Like in the old days, we used to say SVA and that's it. We did not look at pelvic tilt. So if you have a large pelvic tilt, as you have a patient, so you look on the one on the right side, that patient has no SVA. So you can look at an X-ray like that and say, hey, the patient looks great, but you haven't measured pelvic tilt. You measure pelvic tilt on the right side, and it's a large pelvic tilt. What does that do? That retroverses the pelvis. Now their stride is small, so those patients are trying to walk. They cannot really have a good stride because their pelvis is rotated backwards, and it limits their hip range of motion. So their hip is hyperextended. Now, Dr. Schwab and Virginia Lafarge, they've done amazing work on this, and basically they took a group of patients, grouped them into 5, and they found 5 subgroups, found that the higher the pelvic tilt, the higher the disability. So on the group 1, normal pelvic tilt, they were not much disabled, and it was like 20-some%. But obviously, disability increases as your pelvic tilt increases. Why? Because the patient is trying to compensate. So what you're going to see 4 different groups of patients. You're going to have on the purple, on the blue, which is on the left, you're going to see the patient who is not too malaligned. They have a low pelvic tilt, so they're not compensating anything, and they have a low SVA. And those are going to be your best patients. And to the extreme, you're going to have the patient with, so on this purple one where the arrows are, is going to be your patient with a high pelvic tilt, so they're disabled, but they have a low SVA. And then the fully decompensated patients are the ones who are going to have a high pelvic tilt, and despite that compensation mechanism, they have a high SVA. Those are going to be the most disabled patients. So one parameter that's been recent over the past couple of years is the truncal inclination, and we call that T1 SPI. What is T1 SPI? T1 SPI is basically an angle. And the reason you want to measure T1 SPI, or you can use T1 SPI is because it takes out the calibration equation from SVA. SVA is measured in millimeters, so it's anterior decompensation. And again, it depends on calibration of your films. You have to put a magnification marker and do some math in order to get to the values. With the T1 SPI, it's angular. Again, theoretically, you can measure it in the OR. We're still figuring out how to do that. But you can measure it on standing X-ray, and it's going to take into account your spinopelvic parameters. So it's not looking only at the spine, it's taking your pelvis into account. So it gives you a good whole picture about the measurements. So it's a very valuable measurement, again, advocated by Schwab's group. And they found that T1 SPI, which is taking from T1 down to the femoral heads, and the angle with the vertical, there is more significant correlation with clinical outcome measures than the plumb line. Well, why is that? Well, because the plumb line, again, does not take into consideration the compensation mechanisms. Plumb line alone is almost useless. You got to have the PI with it, or at least have also the T1 SPI with it, because that's what's going to give you the spinopelvic evaluation. What's sacral slope? Basically, that's simple. The equation is pelvic incidence, PI, equals sacral slope plus pelvic tilt. So the more you tilt your pelvis back, the more you're making your superior sacrum flat or parallel to the ground. So what's going to happen when you retrovert your pelvis and you're increasing your pelvic tilt, you're reducing your sacral slope because it's an equation. And then you have the SVA we just discussed. It has to be within 5 centimeters from the posterior superior corner of the sacrum. So what are the objectives? I mean, you heard discussion earlier today talking about, okay, we have parameters, we have numbers, we have objectives. So again, I'm not talking here about your 80-year-old who needs a one-level fusion, who may have a problem, we're going to fix, we're going to do the best we can, and we may not match those numbers. But your 45-year-old, your 50-year-old who still has 30, 40 years to go, that's important to do. You want to shoot for an SVA less than 5 centimeters, pelvic tilt less than 20, actually, and pelvic incidence minus lumbar lordosis less than 10 degrees. So, and this was, again, a study. So the consequence of not achieving the alignment would lead to poor clinical outcome. Your instrumentation will fail because now you have all the stress on the instrumentation. You're going to get non-unions. And then you're going to have adjacent segment disease. Even if you do a short construct. Now, we're not saying you should abandon doing a single level TLIF on an L4-5. We're not saying that. All we're saying is make sure you take sagittal alignment into consideration when you do that and do your best. So even if you do a short construct deformity and you haven't met the criteria, you're going to have a really high incidence of adjacent segment disease. Rosenfluh in the European Spine Journal published that last 2 years ago. If the X-rays show that you have a mismatch, you have a 10 times higher risk of adjacent segment disease. And those are the typical patients you see in the office, like that TLIF patient I showed you at the beginning. I mean, that patient is significantly malaligned from the beginning, and now she wore out at L4-5. Now I have to do a revision surgery on her. This is courtesy of Dr. Uribe. He came up with a great system where you can classify these patients. So basically, he refers to well-aligned patients, meaning that you have a within normal SVA, within normal pelvic tilt, patient is not compensating, and the patient is well-aligned. Those are going to be typically your degenerative patients with or without neurogenic claudication or radicular symptoms. You're going to address those basically appropriately. You're going to take care of their objectives, but you don't have to do a major realignment procedure. The moderate ones are the compensated. So you're going to have somebody with an elevated pelvic tilt more than 20 degrees because that patient is compensating. And the SVA is between 5 and 9 centimeters, so it's intermediate. As you see, coronal cob, we didn't even put a value because, as Juan mentioned earlier, coronal cob is really not that significant when it comes as a correlator of clinical outcome. And then you have the advanced deformity. Those are the ones that are severely decompensated, where you have an SVA more than 10 centimeters, and apologize about the bottom, or you have a pelvic tilt more than 25 degrees. So the patient is trying to compensate. Despite the compensation mechanism, the SVA has fallen over. And this is where we have a little criticism as to some deformity guys who will say, well, what is the ceiling of a minimally invasive MIS surgery? What is the ceiling? How much can I do? And somebody says, well, the ceiling is 10 centimeters SVA. Well, that's really inaccurate, because when you say SVA 10 centimeters, you're not taking into account the PT, the compensation mechanisms. So this is a lot more accurate. So, and this is, again, one's classification, where severe deformity would be more than 30 degrees pelvic tilt, more than 10 centimeters SVA, PI minus LL more than 20 degrees, coronal cup more than 30 degrees, and you have rigid deformity in the severe one. Sorry. You have to fix that again. So you move from aligned to compensated to decompensated, as I just explained. So what does that mean? I know what you're thinking. You're thinking, oh my gosh, I have to get a long film on every patient that walks in the office. In my practice, it took me 8 months to train the radiology technician across the hall to do a proper long film. I mean, I had to break tibias to make that happen. I mean, serious. I mean, so what I did at the end, I said to the X-ray techs, I said, listen, you know, either you do it right, or I'm going to start getting long film on every single patient who walks in this institution. And then they did it. Now they do a good job. They put the marker. They do a good job. At a minimum in the office, you got to include the hips. I mean, so you have a degenerative practice. You have everyday patients walking in, right? You got to measure lumbar lordosis, but do yourself a favor and measure pelvic incidence, because now lumbar lordosis is more significant. And then you can do your PI minus LL. If you're within normal and you're looking at a single level disease, you don't need long films. But if you do PI minus LL and it's 30 degrees or 25 degrees, you better get long films. Otherwise, you're going to have one of my patients I showed you earlier. So ideally, you want to have films including the lower limbs. I personally don't do that. I don't have that ability. But this is the recommendation, basically. And the reason for the lower limbs, it shows you how much the patient is hyperextending their hips, how much they're flexing their knees, because that's how they walk. There is value to hyperextension lateral bolsters, and that goes all the way back to traditional conventional open surgery. Basically, what you're doing, you're evaluating the mobility of that level. So if you have a vacuum disc and it moves over the bolster, then you have mobility, and you're more, basically, you can do a lateral with anterior release and get a good correction. Conventional degenerative facet disease grading is really irrelevant here, because the way it's done, it's done by grading osteophytes and how much osteophytes you have. But at the end, all you need to know whether the facet is mobile or not. So it's pretty simple. So you can't apply the WISE-UP classification in this case. You got to look at the shape of the facets. I'm going to show you a couple examples where the facets could become a problem. So you do your X-rays, you measure your X-rays, what are the chances? You have a myriad of techniques you can use, including different osteotomies, T-lifts, A-lifts, PLIFs, you name it, you got it. Traditional posterior osteotomy techniques in general, an SPO gives you about 5 to 10 degrees correction per level. PSO gives you 20 to 30 degrees. Vertebral body resection gives you about 40 to 60, and that's usually reserved for fixed severe deformities. The Smith-Peet and Ponte osteotomies were described long ago for long sweeping curves. So the one you see on the right is a Smith-Peet osteotomy. And PSOs are usually reserved for sharp angular kyphosis or patients with previous fusion. That's a PSO technique. So it doesn't matter whether you had a fusion or not, because you're going to resect all those posterior elements and into the vertebral body. Some statistics, posterior lumbar fusion without interbody, and that has been published. The lordosis obtained is -10, so you lose 10 degrees, -10 to 0. If you do PLIF, T-lif alone, again, you lose 5 degrees to 0. But if you combine PLIF, T-lif with a SPO, and you do a good facet resection and a good osteotomy on the backside at the same time, you get 15, 20 degree lordosis. So if you have somebody who's about to undergo a TLIF and they have significant mismatch, it's something you might want to consider. Do a single level TLIF like that. I mean, we're not saying you should go in and do 4 or 5 levels. ALIF alone, 5 degrees lordosis. ALIF with a posterior column osteotomy, 15 to 20 degree lordosis. And if you do ALIF with comprehensive resection of the annular ligaments bilaterally, referred to as ALIF anterior column resection, gives you 10 to 30 degrees. So traditional XLIF or lateral interbody with a traditional cage, not hyperlordotic cage, gives you 1 to 3 degrees lordosis. If you combine that with SPO, it increases to 27. So that really works. And if you do XLIF ACR, which is what we're going to demonstrate today, you're going to get 10 to 30 degree lordosis. The cages available are 20 and 30 degrees. And this is indicated for focal deformity above effusion. You got to make sure you have flexibility in the disc, and you got to have some flexibility in the facets posteriorly. Of course, if you have adhesions in the front, you got to be careful. You can't do it sometimes because you can dissect the vessels. And no significant stenosis, I'm not sure about that. You always have the option of going posterior and do a laminectomy if you need to. And if you have a tall disc above a PSO. So this is a summary of the options. Basically, your most extreme is going to be your ACR with a posterior column osteotomy, where you combine an anterior release and a posterior release. And that's very similar to a PSO, but it's going to be less blood loss. Again, refresher, remember your objectives, SVA within 5 centimeters, T1 SPI less than 0, has to be a negative value, and the best way of looking at it, you want to make sure that T1 is behind the vertical line. That's how I memorize it. Pelvic tilt less than 20, and pelvic incidence and lumbar lordosis within 10 degrees of each other. And that's going to be your simplest measurement on a standard X-ray, including the hips, without even getting long films. Do that. It's a habit. I do it on every single patient who walks in the office. I'm not going to belabor the technique because we're going to do it in the lab. But anatomic considerations include, of course, abdominal aorta, segmental arteries, iliac arteries, veins, bowel, kidney, sympathetic plexus. It's a direct lateral approach through the psoas, as you can see it here. And look at the vessels in the front on the right. I'm going to show you later a bit more. So the vessels are the closest to the spine and the vein on the vein side. It's closest at L4-5. And I think Rod mentioned earlier you had 2 of those. I had 1 myself. The vein is very close to that disc space in that area. Aorta is actually close at L1-2. And if you have deformity, you got to really pay attention even at those levels with the aorta. So there is an adventitial plane. I'm going to go really quick through these. Adventitial plane between the vessels and the anterior spine. That's the plane you want to dissect. So what I'm looking for, I'm looking at the aorta, at the vena cava, at that adventitial plane, make sure there is a plane throughout. Sometimes you could have a perforating vessel. You may be able to see at the L4-5 level, you gotta look for, you have the importance of your ascending lumbar vein, that you could be in that area. And Juan mentioned earlier that in the OLIF context, it's no different. I mean, this is also surgery, and you have vessels in the area. You gotta have a plan in your mind that if I got a vascular injury, now granted, it's really rare, but if you have a vascular injury, you gotta have a plan in your mind. What am I gonna do if I got an injury? Am I gonna extend the incision, apply pressure, call the vascular surgeon in? Am I going to apply flow seal, let it stop, and then go to the radiology suite? I mean, that's a whole topic of discussion, and I'm not going to belabor that, but I'll be happy to answer questions on that. I think Dr. Tubbs beat this subject into the ground. I can't even be a match for him. I'm not going to even go over that. But basically, you got to get that adventitial plane between the ALL and the vessels in the front and the sympathetic plexus, because sympathetic plexus lies, really close to that, and you're going to make sure you're in that plane and you're not cutting that plexus. So what are contraindications? If you have significant previous exposure anteriorly, like somebody with a previous, let's say, ALIF, and they're kyphotic, and you want to try to revise it, that's going to be awfully hard, and you're going to have the vessels scarred down. Dr. Chapman mentioned about the CTA. I agree with that. I actually talked to my radiologist a couple of years ago, and we started doing CT with contrast, and I think it gives you a good picture of the segmentals of the aorta. And sometimes you're able to spot a abnormal segmental vessel, or a segmental vessel that runs longitudinally. So when you distract, you could rupture that vessel. So that would be a relative contraindication. So if you have somebody with previous, I think my time is out, previous aneurysm, previous anterior disc replacement, those are going to be tough, again, to do it. Now, ankylosed facets, hypertrophic facets are not really strong contraindications if you can mobilize. So vascular anatomy, if you look at this case, look at L2-3, you have this huge osteophytes. And this is a significantly decompensated patient. Massive osteophytes in the front, and scoliosis. So when you distract across L2-3 up here, I mean, that's the aorta here. That's calcification in the aorta. You have those massive osteophytes. So you do run the risk of basically resulting in a tear in the aorta with that. And you can see on the axial, you can still somewhat see the plane, the adventitial plane here. But you have this just massive osteophyte here. So if this patient came today to my office, I mean, I'll do her surgery probably, but I won't do an ACR at L2-3. Facets. I mean, this is like a wise-up grade 10 facet. I mean, you can't even classify that facet. It's tremendous. So the key here is that you're looking at L4-5 and you have pre-existing lordosis. They have a lot of calcium in the aorta too, but that's beside. So you look at the L4-5 lordosis, it's pre-existing lordosis. You don't need a lot of correction. You can still do that very nicely despite those facets. So you got indirect decompression. You were able to restore that. Now, on the contrary, and this is why I kind of criticize the WISE-UP classification, is if you have a sagittally oriented, a sagittally grown facet like that, and this patient's parameters is way off, you want to consider do a facet. Tell me when I'm too long. Okay. Okay. So this is where you want to consider resecting that facet before you do your lateral procedure. Dr. Uribe mentioned the Misonics, drill you can use. I use a high-speed burr, but I do it with a tube. And through the same tube, you go in, resect the facet, and that's where your pedicle screw will go. So you can see the caudal, posted screw over there. Release the facet, get your pedicle screw in if you need to do that. So tremendous correction in that, but the key here is that I resected the facet before I did the lateral procedure. So we'll go over the technique. I'm not going to belabor that. I had case examples, but I think I'm running late. So thank you, Rod.
Great. Thanks, Tony.